Hey, this is Matt Hartman from Pittsburgh, PA, for our RadPath channel. Today we'll be talking about the stomach. And again, my main goal is for you to understand why the images look the way they do when we can correlate it with the gross pathology. So the stomach lecture is going to be very similar to the esophagus lecture. We're going to have some great gross path. And you think of the stomach, it's basically just a big tube. And we'll see what can go wrong with the stomach. Again, the original lecture can be found on the ACR building blocks section. And we have an Anki deck of RadPath flashcards if you want to download that. Check out the About section of our YouTube channel. So, the normal stomach, just like the esophagus, is difficult to study at rest. It's not well distended and is tough to evaluate radiographically. Oral contrast is going to be very helpful whether we're doing CT or fluoroscopy. When we do fluoroscopy, we often do something called the upper GI. We administer effervescent crystals, which will distend the patient's stomach. Then we'll coat that with barium, turn them all around, turn them into a barium milkshake, and get a great look at the gastric mucosa. Our GI colleagues will do endoscopy to evaluate many of these pathologies. So we are doing much fewer upper GIs than we used to, but it's very important to, at the same time, understand what we're looking at and be prepared for these different gastric pathologies. So the normal CT appearance of the stomach, again, if we don't give oral contrast, it's going to be completely collapsed, difficult to evaluate. But if we do give oral contrast, we'll see the nice, thin rugae, several millimeters. We administer barium, effervescent crystals. We get a nice double contrast appearance of the stomach. You can see the rugae nice and thin. This is more of a single contrast appearance of the stomach. You just give the patient a bunch of barium to swallow, it all goes in the stomach, no crystals. So nice sort of like 2D appearance of the stomach, whereas here, more of a 3D appearance, especially when we start turning the patient around. So that's important. Single contrast versus double contrast, if you've never heard that. So, gastric pathology 101. Just like the esophagus, the stomach is a big tube. So if you haven't watched the Intro to RadPath lecture, I highly recommend it. We remember there's a big tube. 1 of 6 bad things can happen to that tube. You can have an innie, an outie, narrowing, dilation, thickening, or displacement. So, quick overview. Majority of the gastric pathologies will be innies, or gastric wall thickening, projecting into the lumen. And again, the radiology imaging is often providing the first clue that something is wrong. The findings are nonspecific. We identify the abnormality, and oftentimes it will be confirmed with endoscopy. So tissue is the issue. Again, from our lecture about getting an adequate specimen, working with the pathologist, our pathology colleagues are often the ones making the final diagnosis. So here's a nice example from a upper GI double contrast of the stomach. Unlike our thin folds, here you have thick folds, much more than 1 or 2 millimeters. This is like a centimeter thick. And again, if you go to the original PowerPoint, you can play with this going back and forth. Take your time with it. So what's our differential for thick folds? Well, if you remember every Hartman differential, Mets lymphoma, that's covered there. But we also have gastritis, varices, Menetrier's disease, which was that past case, and gastric carcinoma. Here is a nice projection. This might look familiar from the Intro to RadPath lecture of a innie going into the stomach. It looks sort of like a mushroom going into the gastric lumen. Well, what's our differential? Well, Mets lymphoma, absolutely. gastric cancer. I'm going to tell you one is Mets, one's primary gastric tumor. To me, they look very similar. Tissue's the issue. You go in. One is metastatic melanoma. One was gastric cancer. So let's do some interactive cases. So remember your differential for thickened gastric folds, and remember tissue's the issue. It's great to come up with a differential, very hard to actually nail the actual diagnosis. Our goal is to get a good differential and make the finding. Here's our first case. So contrast enhanced CT, we said the stomach is difficult to evaluate, especially without contrast, but these folds here, give you a couple seconds, that's the abnormality. Look a little bit too thickened, and the whole stomach is thickened, 2 centimeters. These are interactive arrows. And endoscopy, thick irregular gastric folds. That could be a couple things. And tissue's the issue. This was abnormal signet cells. This was a case of rhinitis plastica, which is one of the variants of gastric adenocarcinoma. We're on CT, we're looking for thick gastric folds, homogeneous wall enhancement, loss of that wall stratification, and notice the lumen is not dilated, it's narrowed like that leather bottle. Okay, our second case, 82-year-old with nausea, 15-pound weight loss. Do a CT here, we have oral contrast. A couple things going on here. Some irregular fold thickening. That is mass-like. Again, it will be our similar differential. Could be Mets, could be lymphoma, or could be a focal gastric cancer, as we have here. Again, the important thing is making the finding, describing that finding, again, using one of those 6 pattern words will help you make the accurate, make the findings and then come up with a differential. And here is the endoscopic view, focal mass going into the lumen. Okay, our third case. 50-year-old man, abdominal pain, history of NSAID use. What are we seeing here? Stomach's not well distended, that makes it tough, but there are definitely thickened folds here. Back and forth, thickened folds diffusely through the stomach. This is a case of acute gastritis. And the fold thickening is non-specific, but with that history of the NSAID use, that points us in the right direction. Other gastritis can be caused by H. pylori, trauma patient, burn patients, autoimmune situations, ingestions, and certain complications related to HIV. Okay, our next case. This is a 38-year-old abdominal pain, low protein. This might look familiar. Here's our double contrast. Here's our CT. A nice example of being able to distend the stomach, this time with fluid. And we will see our thickened folds. Really here, it's not as diffuse as the other one. It is really along the fundus and the body of the stomach, so different from our NSAID gastritis. So this is more of an advanced resident level topic, but for any med students who are super motivated, this is very characteristic of Menetrier's disease. Idiopathic hypertrophic gastropathy, you get the fold thickening in the body and fundus and sparing of the antrum. Okay, our next case. This is a twofer in that there are several findings here. We have a huge spleen and we have our stomach here. This is a 55-year-old abdominal pain. Huge spleen, and stomach's not well distended, but very similar to other cases with gastric wall thickening. I think we have diffuse wall thickening here. Hopefully everyone agrees with that, with a big spleen that has some low density masses in it, and low density, really low density, it looks like air in there. So remembering every Hartman differential, Mets lymphoma, that's a great guess, especially with a big spleen, making us think lymphoma. And that was the case there, gastric lymphoma. So this is pretty advanced lymphoma to be involving both organs like that and the officialist communication there, but lymphoma nonetheless. Okay, our next case. This is a little bit of an eye test. So we're given the history of melanoma. We're looking all over, could be anywhere, could be in the skin. Liver is a great place to look. This lecture is on stomach, so we'll focus our attention there. And we missed it, there's our arrow pointing to a big innie in the stomach. I will say this is sort of subtle, but it is a finding nonetheless. And similar to earlier case that we saw of melanoma to the stomach, it's a case of gastric metastases. So it can either spread directly, esophagus and pancreas, live right by the stomach and spread right in. Melanoma is one that really likes to go to the stomach, hematogenously, so it's a good place to be looking if you have a history of melanoma. Can be solitary, could be multiple for Mets, but my experience, the cases I've seen, it's usually solitary. And if you see the target or bullseye, if you hear those words, those are good descriptor words. Always make you think Mets if you see a targetoid lesion. And we have a bonus case, 60-year-old female with abdominal pain. So this is a tough one. It's a non-contrast scan. I will say we gave some oral contrast, so no IV contrast, but there's some oral contrast. And that is sort of the crux of this case. I'll give you guys a couple of seconds and see if we made the findings. I'd say, hey, the stomach doesn't look too bad. And I'll agree, it doesn't look as thickened as some of those other cases we had, but we do have some air there. And the most important finding is this high density stuff. This is the oral contrast. It's not in the stomach, it's outside, it's anterior to the liver. Plus we got a air fluid or air contrast level there. So air outpouching from the stomach, extraluminal contrast. How did it get there? Well, this is a huge gastric perforation from an ulcer. Again, we'll put the annotations in there. There's our air-filled ulcer. There's our extraluminal contrast with a air fluid level. So this is a big outie. So to summarize, gastric pathology is often nonspecific when we make the findings. It's often thickened walls or thickened folds. So remember that differential. And if you forget it, just remember every Hartman differential, Mets and lymphoma, almost every differential. Remembering the findings are nonspecific, tissue's the issue. Our GI colleagues are going to sample those abnormal areas. We're going to tell them where to sample. We'll help stage, looking for those tumor tipping points. Are there Mets anywhere else? Is there adenopathy? We will guide the workup for the patient, but ultimately tissue's the issue, and make the definitive diagnosis. Thank you very much.